Hello, everybody. So my name is Dominik Linz from Maastricht in the Netherlands, and welcome to the Journal Club of the Arrhythmia Academy. Today, I'm here together with Edvard Sandberg and Dan Atar. Edvard is from the hospital in Arendal, and Dan Atar is from the University of Oslo. So today we will talk about a very recent Europace manuscript published in this journal fresh off the press in February 2023. And this journal and this manuscript is entitled Fully Digital Self-Screening for AF with Patch ECGs. And Edvard, so maybe you can start now presenting the content of this interesting manuscript, and then afterwards, also together with Dan and you, we will discuss the content.
Thank you. So first of all, dear colleagues, I would like to thank you for the invitation and for the opportunity to present the study on the behalf of the research team. As you all know, atrial fibrillation is the most common arrhythmia in the world, and its prevalence is expected to triple within the next decades. It's a complex clinical challenge for several reasons, and one of them being that many have the conditions without knowing it. If left untreated, it is associated with increased risk of morbidity, mortality, and healthcare costs. Therefore, international guidelines recommend to consider screening for AF in people at 75 or those at high risk for stroke. However, how to screen and how to organize this remains unclear. The aim of this study was to assess the feasibility of a fully digital self-screening procedure and to assess the prevalence of undetected AF in Norway using a wireless continuous patch ECG recording system. The screening device used in this study was the Norwegian ECG 24/7 smart heart sensor. The system consists of the following: a reusable sensor, a disposable ECG electrode patch, a medical grade smartphone application. And these are all communicating remotely through a secure cloud service with real-time ECG analysis by a dedicated AI system. Okay, so the study was conducted like this. We openly recruited people to self-enroll into this self-screening procedure by promoting a study homepage containing general information about AF and the study's purpose on various media platforms, mainly on social media, like this Facebook post. In order to participate, an entrance test fulfilling the inclusion, no exclusion criteria located on the study homepage was necessary to pass. The questions asked were based on the CHA₂DS₂-VASc risk score, but they were translated into layman's term. If passing the test, meaning 2 or more points on the CHA₂DS₂-VASc score, they were required to provide their digital consent for study participation. Then they self-reported clinical characteristics, previous disease, medications, and symptoms in a web-based questionnaire. The screening device was sent by post home to participants free of charge. They self-applied the screening device, connected it to their phones, and performed continuous long-term ECG monitoring in their own environment. All ECG recordings were first automatically assessed by the integrated AI system, then manually by a physician. All participants received a digital report in the ECG 24/7 application on their smartphones. The reusable part of the device was sent back to the study center in an already addressed and prepaid envelope. And in case of any arrhythmia, they received an additional phone call with instructions. But due to the large geographical spread, they were advised to contact the GP, handing over the report and undergo further treatment assessment. So between January 2021 and June 2022. A total of 2,118 individuals fulfilling the inclusion criteria were successfully included in the study. The study population consists of more than 74% women with an average age of 70, and the mean CHA₂DS₂-VASc score was 2.6. 87% performed the ECG test, and the mean ECG monitoring time was more than 6 days. AF was detected in 2.2% of the participants, and more men than women were diagnosed with AF. The number needed to screen of those performing the ECG test was 45. In those with detected AF, AF persisted throughout the recording in 5 participants. Paroxysmal AF was present in 88%. The median ECG test duration before the first episode of AF was 47 hours. Nightly episodes of AF occurred in 81%, and participants with paroxysmal AF had an average of 2.8 AF episodes, with a mean total AF duration of nearly 20 hours. So, in conclusion, this study demonstrated excellent feasibility, and it ensured a nationwide inclusion during a global lockdown in a short time interval at low personal and financial costs. Thank you.
Yes, thank you very much, Edvard, for actually this presentation of this very, very nice study. So I think this is also another example of a covert, output, more or less, right? So during COVID, a lot of centers were very, very creative in still getting the best care of the patients in a digital way. And yeah, just congratulations to you and the complete team, of course. So let's go now step by step through this manuscript and focus maybe on some interesting points. And I would start, Dan, with you, actually. So 87% uptake, that's unbelievable, right? So you ask patients, just use this patch, and 87% eventually did this. So how was this possible? What do you think was the trick behind it?
So this is a really important entry question, and again, congratulations, Edvard, very nicely presented. So we must be aware that Corona had the impact that people did not visit their GP or their physician physically in many cases, but were somehow deploying other channels, and this recruitment strategy in this study was exactly like that. It was via social media. So you might say you kind of pre-select a population, obviously of elderly, where the use of social media in some way was already accepted or even used on a daily basis. And that definitely played a role by the fact that so many actually achieved the correct usage of this completely independent setup of the study.
Yes, this is also what I actually noticed in the limitation section a little bit. So it was recruitment via social media. This actually means you need a 65-year-old using social media. Then actually a mobile phone needed to be present, a bank ID needed to be present to actually digitally onboard. So you need those older 65-year-old patients who actually have this available. So meaning that a baseline digital literacy already needed to be present. But nevertheless, 87% is really a great achievement. So that's certainly showing the feasibility of this approach. Yes,
exactly. And I would say, since this is basically a methodological study, that was one of the really important lessons from this entire enterprise.
Yes, very impressive, certainly. Edvard, a patch ECG was used, right? But actually for screening, why ECG, why not PPG? And actually why this patch, which recorded, I think, 180 hours? So why not shorter? Why not longer? So what was the idea behind that?
Well, first of all, there have been some great large studies already conducted with PPG wearables like the Hinavi, the Fitbit study, and Apple study. And all of them have, in comparison, they have rapid inclusion. But in order to diagnose atrial fibrillation today, you need to confirm it by ECG. And to date, we cannot use that type of technology to diagnose AF. But long-term monitoring of your heart rhythm is perfect to give you a clue if you have some problems or you are experience any arrhythmias. But like I said, you need an ECG to confirm what type of heart rhythm disorder it is. And for the second question, the screening device, the ECG 24/7, it has a battery capacity for up to 14 days. But the quality for the ECG signals is up to, I will say, 7 to 10 days. So that's the limitation of that technology.
Yes. So actually deciding on the technology, it was mainly ECG because it saves you actually one step when you screen for AF, right? So if you start with PPG, you still need the confirmation by ECG. If you directly use ECG, you already have the ECG, so you can diagnose. And then the other thing is, why not longer, why not shorter? Mainly a little bit also based on the battery, but on the other hand, also probably the quality, which decreases the longer you use this device, right?
Yes, that's true. And like you can see in the Fitbit, the Apple, and the Huawei study, when they changed from the PPG technology to the subsequent ECG electrode patch, there was not many people did that. So that was a weakness, I think.
Yes. Back to Dan. So the CHA₂DS₂-VASc score. This is, of course, always very, very important when it comes to assessing whether a patient with atrial fibrillation is at higher risk or not to get a stroke. The CHA₂DS₂-VASc score in this study was mainly based on self-reported risk factors and components of the CHA₂DS₂-VASc score. And even, I think, if I understand this correctly, translated into a patient understandable language. So how accurate do you think is actually the self-reported assessment of CHA₂DS₂-VASc? And do you think that it more over or underestimates the CHA₂DS₂-VASc? So what are your thoughts about that?
Yeah, this is an important methodological aspect, because it is absolutely clear that self-reported CHA₂DS₂-VASc will not entirely reflect the CHA₂DS₂-VASc that you would have achieved by a physician consultation, writing down all the criteria. If we look at a comparison with the stroke stop study population that was 50, 70, 75 and 76-year-olds, and then assessed their CHA₂DS₂-VASc in comparison to this study, there is a little difference, which is probably partly due to what you mentioned, namely the self-reporting aspect. We don't actually know whether there is an underreporting or an overreporting, but the suspicion is probably that a few patients do not really report correctly on heart failure, on hypertension, and so on. So it is maybe, but we don't know, it is maybe a tendency to underreporting. And in your study, Edvard, the CHA₂DS₂-VASc mean was 2.6. And as you said, with a capture of 2.2%, it may actually have been a bit higher of a CHA₂DS₂-VASc score.
Yes. But at least, well, this is what you, of course, get when you screen, right? The alternative would just be to link this directly to a registry. Even within a registry, we don't know how accurate the CHA₂DS₂-VASc is actually, right? So I think this is, of course, still the challenge. But the thing is, of course, the treatment of AF doesn't stop with detecting AF, right? So the one thing is, of course, detecting atrial fibrillation. This worked actually in your study, and you found 2.2% of the participants who actually had atrial fibrillation. But this alone doesn't prevent any stroke. So you need to have this transition to the treatment. And Edvard, so how was this actually ensured? And do you think this already works perfectly, or is there still something to improve? What are your learnings there?
So in the original study procedure or protocol, we didn't apply the ethical committee to investigate this question. But after the study was finished, we applied for this in the ethical committee, and we just have the results. So almost everyone that was diagnosed with atrial fibrillation actually started on oral coagulation. And more than 90% actually did go to their GP. I think it were only 3 people that did not start on oral anticoagulation, but they all had in common that they were 65 and female, without no other risk factor. So there were 2 important parameters that we measured when we were asking the patients. One, did you go to your GP as instructed? And 2, did you start on oral coagulation? And almost everyone went to their GP, and almost everyone started on oral coagulation.
Yes. But then, of course, the anticoagulation is also just the A of the ABC, right? So then the second part is, of course, better rhythm and rate and symptom control, and particularly in the scenario of EAST, right? So where we probably should really focus quite relatively early of the disease trajectory. This is, of course, also still something which needs to be investigated carefully, whether actually all those patients who are diagnosed or who are detected in those screening approaches actually have access to early rhythm and rate and comorbidity management, right? So that this is, of course, also something really to focus on. Then the other thing is, of course, also the yield, right? So everybody is talking about this, how many patients need to be screened, and what do you get out of it? Is it actually worth screening? And then it also comes to cost effectiveness and a lot of other things. 2.2%, and the number needed to screen 45. Is this good? Do we need to be better? Do we need to change the strategy to get the numbers down, the number needed to screen down? So what are your thoughts there? Maybe also considering the approaches from other studies.
Yeah, so that's really nailing down to the essence here. First of all, a number needed to screen of 45 is really good. I mean, if we compare again to stroke stop, it was more than double. So clearly, this is a success in itself. But the truth of the puddle is indeed, as you mentioned, let's say all of these detected AF patients go over to anticoagulants. Does it make an impact in the long term on their morbidity mortality? That, of course, has not been the aim of this study. That would be the follow-up study, which I know Edvard is working on. But this is the real question. And here we must also remember that, let's take the LOOP study that had another cutoff. They had a 6-minute detection cutoff for atrial fibrillation, as opposed to the 30 seconds with Edvard's study. And practically all, like in this study, in the loop study were switching over to anticoagulants. Yet it did not make an impact statistically on stroke rate. And therefore, I think we must be very aware of the fact that subclinical AF may or may not be the same as a clinical AF. And of course, this is very much related to the technology. If you have a loop recorder implanted for 3 years, it captures different phenomena than Edvard's, let's say, 10-day monitoring. And it would be completely different if you had just EKG based, namely, most likely the patients go to a physician because they have some kind of symptoms, some kind of reason to take an EKG. So all these aspects are different in the various studies. And of course, the main achievement of this study is just to show that this is feasible, and with a capture rate of 45, a number needed to treat, which is quite good.
Yes. Yeah, well, I think I can just echo what you're saying. So as somebody who's reading this manuscript, really congratulations to the complete team for first setting this up, second, during COVID, third, actually in a completely digital way, and achieving as many patients who were interested to participate, right? So it was social media promotion of this this complete program, and you reached actually quite a lot of patients and who were not patients at this time point, and actually 2.2 of those participants eventually became patients who most likely can profit from the results of this study. Concerning outcomes, well, this is also what we have discussed. This is probably this study 2.0, right? So this will most likely follow. And well, we are all very curious, of course, in those results also. So
exactly. And in this context, I just want to mention the number that we need in such a version 2.0 study will be, of course, much larger yes, in order to have a real robust clinical result at the end.
Yes, no, absolutely. And particularly also considering the results of Stroke Stop and the other studies, probably be very conservative in the power calculation, because eventually we actually learned that the effect of treating atrial fibrillation in those patients who are detected in those screening programs, yeah, we need a lot of patients to show actually an effect, and I think that's for sure. So, well, thank you everybody, and thank you Dan, thank you Edvard for taking the time to talk about this very interesting manuscript. And yeah, this was the Journal Club of the Arrhythmia Academy on this Europace manuscript, and yeah, just follow the upcoming manuscripts also on Europace. Thank you very much, and see you soon.
Thanks a lot.
Thank you.